Welcome everybody. I want to welcome you to this video, Improving Care Team Communication and Coordination for Immuno-Oncology Survivors. First, I want to introduce to you Dr. Tom Smith, Harry J. Duffy, Family Professor of Palliative Medicine, Professor of Oncology at Johns Hopkins Sidney Kimmel Comprehensive Cancer Center. Next, we have epidemiologist Robin Yarbrough, Senior Scientific Director, Health Services Research at the American Cancer Society. And finally, Regina Jacob, Assistant Professor, Clinical Medicine and Director, Social Determinants of Health Curriculum, Internal Medicine Residency Program, and Medical Director of Temple Internal Medicine Associates. Thank you, guests. So we wanted to start out today talking a little bit about how we should define or be thinking about survivor and immuno-oncology treatments. We first want to reaffirm the broad NCCS definition of survivor and why it's important. We're thinking about survivorship as anyone diagnosed with cancer from the time of their initial diagnosis until their death, or living with, through, and beyond cancer. Survivors on immuno-oncology treatments may or may not end active treatment. So thinking about post-treatment survivorship is not always the right framework for this population. Some people may be able to end treatment, but some are expected to be in active treatment for an extended time period. And so we want to talk a little bit about why it's important to think about them as survivors as well. People who aren't treated with curative intent can benefit from survivorship care plans, but may have some unique experiences compared to those who respond to curative treatment. We want to acknowledge that this term is complex and not everyone loves the word survivor or survivorship, but we want to explain the definition we're using for this video. I'm wondering, can you guys speak to why care coordination and communication is so important for patients on immuno-oncology treatments in particular?
Well, I can speak from the primary care side since I practice as a primary care physician as well as educate residents in internal medicine. I can tell you that a lot of the challenges that we face on the primary care side is a lot of times we don't know the full treatment that a patient has received. And so that can sometimes be a big challenge to just bridging the gap between oncology and primary care and how that affects patients long term. That bridge in care can actually also contribute to some of the anxieties that patients often have. There is a lot of anxiety for patients when it comes to what they feel like a separation, what they feel is a separation from their oncologist back to primary care. And it shouldn't necessarily be that way. If we can improve our communication between oncology and primary care and all of the other care teams that are involved, then the patient should never have to feel like they're leaving one doctor for a different doctor. And that's what I'm hoping is part of the same conversation that we have going forward in terms of survivorship care in general.
Speaking to the oncology and palliative care side, I think immunotherapy is different. People can stay on it for an extended length of time, have extended survival when they didn't before, particularly melanoma, kidney cancer, and some others. Even lung cancer, 15 or 20% of people are alive at 5 years. But it causes a whole host of different toxicities from the chemotherapy and radiation therapy that we're used to seeing. Pneumonitis happens in about 19% of people off clinical trials, colitis, which can be life-threatening. And not only the oncologists and the palliative care specialists have to recognize these, but primary care people have to know too that it might not be the disease that's acting up. The other thing that's different is that the toxicities don't happen in the first 3 weeks, not like losing your hair or throwing up. The toxicities can come months or even years afterwards. So somebody can be doing really well and then suddenly develop classic hypothyroidism or significant colitis. And you need to be able to recognize that, put the person on steroids, stop the drug if they're still on it, and manage from there.
Yeah, and I would like to add that one other important difference about some of these treatments is they're very expensive. And so as Tom mentioned a moment ago, some of these effects can be cumulative, including some of the financial adverse effects. Those also can be cumulative and can last many years after diagnosis and completion of treatment.
Thank you, Dr. Yabroff. That was a perfect segue to my next question. Maintaining employment, health insurance, and managing the financial toxicity of cancer treatment is especially important for immuno-oncology patients. I'm wondering what the panelists think about what care teams should be doing now to communicate and coordinate immuno-oncology survivorship care.
That's a great question. I think one of the most important things is questions to patients about how they're coping. And also importantly, that all patients are asked about some of these challenges related to employment and financial hardship. If only some patients are asked, it can stigmatize those patients that may appear to be socioeconomically disadvantaged. Whereas if all patients are not asked, it can also disadvantage those who may appear to be socioeconomically advantaged, who may actually be struggling with employment or other financial issues. So again, I think really important to make sure that conversations happen regularly and they happen with all patients.
I think it's really critical at the same time to be trying to maintain quality of life, hopefully for a long time, but sometimes not. And that includes addressing symptoms and side effects. You have to ask about them. Patients are just not going to volunteer most of the things that we're interested in knowing about. And finding and fixing symptoms improves outcomes. I think Ethan Bosch has shown that pretty convincingly, that fixing symptoms improves survival by 6 people out of 100 at a couple years. Better than a lot of the new drugs we've had for a long time. So you have to make sure that someone in your office does a comprehensive, multidimensional assessment like the Edmonton or Memorial Symptom Assessment Scale pretty much at every visit, or at least once a month. Don't just ask, how are you? Oh, I'm fine. People won't tell you about psychosocial issues, sexual issues, other things that are bothering. Another thing that I find in my own practice improves quality of life of patients, families, and frankly, me as their oncologist is to get palliative care involved early and often. Getting into immune therapy should almost be an automatic referral for palliative care consultation. The other thing is it doesn't have to be the oncologist. Social workers are really good at this. Advanced practice nurses are good at this. Just make sure your office has a coordinated plan to get people into palliative care early, like the American Society of Clinical Oncology suggests.
So maybe one of the take-home messages is, as oncology teams, you don't have to be the expert, but what makes you the expert is having these key relationships with other partners. That may be subspecialties, emergency medicine, or it might be your psychosocial providers. But knowing those people might be the best way to support your patients going through immunotherapy.
And part of that challenge is also back to the education side. So if we can broaden how we talk about adverse events that happen after immunotherapies, we can also broaden how we educate in the residency level or in the medical school level so that everybody in every context is aware of these issues and knows how to deal with them when they show up. So if the patient presents to the emergency department, those residents and attendings would be able to handle that situation. If the person is admitted to the hospital and is on a hospitalist program or a hospitalist under the care of a hospitalist, then that would also be addressed at that level. So I think we have to sort of initiate some of these education topics within all of the educational forums that we have in residency programs and medical school programs so that everybody's aware of these on all of these different fronts where patients can show up.
I want to check in with the panel. How do you think the care team should approach care transitions and continuation of care?
I'll jump in. I don't think it has to be as complicated as we think we need to make it sometimes. You as the oncologist or the oncology team need to start with a short, simple summary, no more than a page of what medicines the patient got, what the intent of treatment was, what the future options hold, and what possible side effects and toxicities to look for. That's critically important with immunotherapy. I have my own 3x5 index card that I give to the patient and the family. The ACCC has a wallet pack of things to look for, and it has the same information for the most part. It's got what drugs they got, when they last got it, when to look for toxicity, and what toxicities to look for. And that's critically important and easy and simple to do, and it should be a great resource to most practicing oncology offices.
And speaking as a primary care doctor, if I were to be able to get that 3x5 card that he mentioned in the chart somewhere, it would make our lives so much easier. And I think it would also ease a lot of the patient anxieties themselves, because then there's more people in the care team to call if there is an issue, because not only do they know what to look for, but all of the people on the receiving end of those phone calls also knows what to look for. So I think that is critical to the long-term survivorship care plan in general, which is just everybody on the care team should be involved and should understand what's happening.
I like how that really empowers the patient as well to kind of take charge and have some information that they can share with their care team as well.
I think the transition to primary care is complicated, as Regina says. Some primary care physicians really want to do this. Some hospitalists really want to do this. They're interested, they've got the time. This might be a significant chunk of their practice. For other primary care physicians, this may be 1% of their practice. That's why you need to, if you're referring somebody back to their primary care physician, you really need to pick up the phone and say, I'd like to send this person back to you. Here's what has happened, and here's what to be on the lookout for. And by the way, I'm sending you a one-page fact sheet you can put electronically in the patient's chart, so you can be aware going forward.
Yes, and speaking on the primary care side, it's exactly what you said. Sometimes these transitions are, fixed by warm handoffs, and a warm handoff would be, information on what happened, a phone call from the inpatient doctor to the outpatient doctor, a phone call from the oncologist to the primary care physician. These have all been shown to improve patient care. And so it is something that I would say is critical to the survivorship care plan in general, and that's focusing on the transition. Even if it's not a black and white transition, but it's just coordinated care going forward, it's super important that all of the people in the care team are aware of, what their role is and who to reach out to when something goes awry, and the patient should know it as well.
Well, with the current economic landscape, people losing jobs, especially in the context of COVID-19, people potentially losing their health insurance, all this added stress isn't going away anytime soon. I'm wondering if the panel has ideas about how we can have conversations with patients up front about costs.
So I think that these conversations can seem complicated. If you have 100 different patients, they may have 100 different types of health insurance coverage, and they may also be at different places in their deductible at different points of the plan year. And it's also true that most oncologists don't know the costs for those specific patients, but I do think there's a basic understanding of whether treatment will be the cost of a fancy cup of coffee, a used car, or 4 years tuition at a private school. And understanding the magnitude of costs can be very important for patients and their families. Another point I'd like to make is that these conversations do not have to be the sole responsibility of the oncologist. Conversations about costs can include multiple members of the care team, could and should include multiple members of the care team to ensure that as things change over time, that patients have as much information as possible.
If I can support what Robin said, it doesn't have to be complicated, particularly with so much changing in the past year or so. I just routinely ask my patients, are you having trouble paying for your care?
I also want to add that the cost of these treatments is not just the cost of the drug. There are many more costs of care that patients pay for out of pocket. There are also a number of other costs that patients bear, including travel, if they are seeking care farther away from home, and lodging for those long distances. And then importantly, while patients are receiving care, they may or may not have paid sick leave, and they may experience lost income while they're receiving care. So many cancer survivors and also their caregivers take both paid and unpaid sick leave.
One challenge I've seen recently is with my patients who are getting CAR-T treatment, and they have to have a caregiver with them for maybe up to 60 days post the treatment. The patient may be able to get sick time for that time, but often the caregiver can't take disability pay for that time because they're not the one that's disabled. So these families are going without income for two breadwinners throughout their cancer treatment. It's really hard on them.
I think it's important when you're seeing a person for a complicated new therapy that you really ask, do you want to discuss how much this might cost? You might not have the exact dollar figure, but you're going to have a pretty darn good estimate from your business manager, and you're going to have a much better estimate than the patient and the family. So if you're looking at $170,000 a year, you should really share that with the patient up front so that they should know what they might be responsible for. I think that idea of price transparency is really critical.
I just wanted to echo a little bit of what Robin and Tom were saying, is just that, you know, the reality is the COVID-19 pandemic highlighted many costs that we weren't even aware of before. And so having those conversations with open-ended questions is really important, because we started to see things like childcare that people weren't able to afford, or now being responsible to keep their children at home outside of school. So then how are they supposed to leave in the middle of that to go get cancer treatments, or any treatments for that matter? So there's a lot of costs that I think the pandemic sort of exploited, that we are actually, it wasn't on our radar before to ask. So I think those open-ended questions are extremely important. Going back down to just sort of, these are sort of social history questions that we were always asking before, are now even more important in the setting of what the pandemic has done to bringing these issues up to light. And yes, it stretches beyond immuno-oncology, it stretches into oncology, it stretches into all sorts of medical care in general, because these costs are just unanticipated costs that we've never really had to incorporate before.
All right, to close our time together, I would love to hear from the panel your recommendations and key takeaways to cancer centers and providers in regards to the care of those on immunotherapies.
Well, I would say from a medical system perspective as a whole, we need to focus on the education of immunotherapies and their toxicities in general. Since these therapies are so new and their toxicities are slightly different from what we're accustomed to when compared to traditional treatments with chemotherapy and radiation therapy, we need to dedicate the time to educate everyone involved in the care team so that patients can feel confident in their care in general.
So I want to emphasize the importance of routine conversations with all patients about employment, health insurance coverage, and expected out-of-pocket costs, because these can change over time and any adverse financial consequences can be cumulative. Oncologists do not need to have sole responsibility for these conversations and can easily work with other members of the care team. These conversations are especially important in the context of the COVID pandemic, with widespread unemployment, loss of employer-sponsored health insurance coverage, and the potential for financial challenges for patients and their families.
Some things I've learned to use in my own practice are to be explicit about asking about symptoms and trying to use a multidimensional quality of life instrument like the Edmonton Symptom Assessment Scale or the Memorial Symptom Assessment Scale. Doesn't matter which one, but use something that asks about specific symptoms, pain, nausea. It's only by making them visible that you can put them on the problem list and start to solve them. There's very good data that improves quality of life and probably overall survival. The next point I make is to ask the patient, how are you coping? And ask the family, how are you coping? And ask specifically, what are your concerns going forward? What's your understanding of your situation? And then to emphasize Robin's point, ask about costs. Are you having trouble paying for your medical care?
Well, thank you so much. That was excellent. I want to thank Dr. Regina Jacob, Dr. Tom Smith, and Dr. Robin Yarbrough. Thank you so much for your time and energy and sharing your expertise with us. Please be sure to visit accc-cancer.org/immunotherapy to stay up to date on the latest tools and resources around survivorship care for patients who've received immunotherapy. We have a publication called Survivorship Care Plans for Patients Receiving Immunotherapy. And we have special episodes on the Cancer Buzz podcast, like Survivorship Care After Immunotherapy. And we have additional resources like the ACCC IO wallet card. Thank you so much.